This seminar is particularly focused around peer research or lived experience research. And so we've got some really interesting projects today that people are talking about. So we're going to start with Professor Margaret Peggy Swarbrick. So Peggy and I worked together from about 2016-17, I think, on a study in collaboration with the World Health Organization, looking to feedback service user perspectives on the ICD-11. And we've sort of stayed in touch and carried on trying to collaborate and collaborating since then. So Peggy is Associate Director at the Centre of Alcohol and Substance Use Studies and a research professor at the Applied Department of GSAPP. Over her career, she's made significant contributions to the body of literature in occupational therapy, nursing, and community behavioural healthcare practice, focused on topics such as the 8 dimensions of wellness, wellness coaching, peer support, health disparities, and social determinants of health, financial wellness, employment, trauma, and self-care. That long list is making Bonnie smile because we can never get over how much work you do, Peggy, in our department. Peggy's known for bringing the voices and needs of people to the table by collaborating with the peer community and family groups to identify and address social determinants that are barriers to recovery and wellness. She's created self-care wellness programs for people in recovery, caregivers, families, youth, and professionals. As co-investigator, consultant, collaborator on patient-centred outcomes research institute grants, as well as National Institute on Disability, Independent Living and Rehabilitation Research, National Institute of Mental Health and Substance Use Abuse and Mental Health Administration. She has contributed to significant research and has been lead for developing training and intervention manuals for many years over these projects. For many of these projects. So as I've said, she was co-investigator on our Include study and she's worked for many years at the collaborative support programs of New Jersey Wellness Institute and developed a strength-based 8-dimensional wellness model to promote recovery from mental health and substance use. So that's what you're talking about today, Peggy. So welcome, and a very impressive CV. So we're very glad and grateful to have you.
Well, thank you so much for having me, and I'm going to put the screen up there. So I'm really, again, like so many things, I'm kind of, I'm old. I've been around a long time, so now it's going to make me open it again. Oh no. It will pretty much, let's see, upload a copy. Hopefully the copy comes up. So I really want to just kind of give you a little bit of a framework of this model that I've been working with that's really helped me to frame many of the works that I've done. So kind of highlight the 8-dimensional model that really has led, it's how it developed, evolved, and how it's led to these co-produced tools and research projects that I've been pretty involved in for decades. And I'm apologizing for this thing going so slow. It came up a minute ago. So I'll talk a little bit about the overview of the model. Oh, good, here it comes. We always want the slides because it makes it so nice. So kind of really seeing, I think the whole thing's there, but where, as mentioned, where I'm at, I'm like just so into all of this work and been so important. Again, going to highlight the model really quickly and then just highlight some of these projects, many of them, and I'm going to put myself on the visual there just so you can see the slides instead of me popping in and out there. Some of these peer-led fairs and some of this solution suite project, just to give you a sampling and a taste of some of the work. So wellness, the idea of wellness is like this conscious, deliberate process where we become aware of and make choices for a more satisfying lifestyle. This came to me at a very young age. I was someone who decades ago faced some significant life disruptions at an extremely very early age, and it influenced me into my early adulthood. And one of the things that happened, thankfully, was I got this idea of wellness. Like, I did not want to be ill, and it was like a real persistence to understand wellness, how I could do my own wellness. And I was always not the best person who wanted to deal with traditional services and things like that. So I started to develop this wellness for myself, and thankfully I was able to make my way into education goals very slow and steady and start to bring this into my work. So you can see even back to 1997, the work really started probably in the 80s formally in my work as an occupational therapy assistant in a state psychiatric hospital. People wanted wellness. So I started, wellness was around. We all could look at the history of wellness and how the concept has evolved. But people in mental health and addiction and people with trauma wanted to have wellness, the idea. So over time, I've evolved it to this idea of an 8-dimensional model for behavioral health that in the United States became very, very, like I was talking about it, developing things for quite a while. But then the Substance Abuse and Mental Health Administration, when we came with some data, and I was bringing this data all along, but I was still not even finished with my PhD at the time, and I'm bringing stories. People didn't always want to hear stories, developing things. And finally, the Substance Abuse and Mental Health Administration organized. They have, a very good pattern of organizing people like you're here, hearing the voices, and said we want to focus on wellness. People are dying 25 years before the general population. There's a lot of these health risk factors, and that's really one of the reasons I really saw it wasn't just emotional, social, intellectual areas where you see in some models. There's the occupational, the financial, the environment. I really evolved it. If you see in my work, it went from like about 5 to 6 to 8 dimensions. But personally, it started, but eventually hearing the voices of people on the ground, seeing what was happening, we saw that it was so important. But what really was appealing to this model was that it became this lens that people could see themselves. And that's what I found for myself, for so many people. We could see we're not just this broken person. We have this diagnosis, everything focused on the symptoms and problems. We could start to think, okay, I might have this mental and emotional dysregulation, but physically, okay, what can I do to manage that? And socially, intellectually, I want to pursue these goals. We could see ourselves from this model. It could be a lens for supporters. And particularly, again, I think it was what I really found too, it became an equalizing playing ground for professionals and even researchers to understand we all want wellness. It's something we all can relate to. So it became this focus, and the model really became very, a big focus, again, in the public mental health system here. And I got to tell you, it became the language, the verbiage. A lot of people weren't fully operationalizing it. There's evolution of pocketing of, operationalizing it. But that's one of the things I did. But again, with the model, just give you more before I tell you some of the exact, how it translated into some co-produced projects, was the idea that you have strengths and wellness habits, build wellness habits. Like what you focus on expands. And I found that, like, I just tend to be a half glass empty, looking for the minefields, looking for, my mind goes to a negative focus. So I had to learn again how to shift it, and having that kaleidoscope wheel, I love the wheel we created, became a way to kind of think about how to shift. Okay, physically, what can I do? Socially, intellectually, and not see myself as just one area, but how it all influences each other. Understanding we have strengths and build wellness habits, build wellness habits. And I was very fortunate. Again, my mother was one person who really definitely helped me with this, even though I didn't appreciate it at the time. But she really helped to ingrain this, which it didn't really hit for decades later, to understand, to shift the possibility. Someone who believes in you, and she really helped me to see you have these strengths, and then really built this model. And just some conceptual ideas about the model. It's really about our attitude. I really try to help think about how do I shift my attitude, try to find the right balance for me at different times, and then idea of control. It's really a big thing is using the serenity statement. And I did a lot, and a lot of people do, focus on a lot of the, not necessarily full 12-step, but understanding it. So just to think about how we've been able to kind of operationalize this, it's focusing on those strengths. And I definitely, after this, I'd love for you to take this quiz. We don't have enough time, but we have this little quiz we have people do. I've developed all these kind of little tools for people assessing themselves. and we'll give you the link to it. But it's a really little cool quiz, and people will see, oh my goodness, I have these strengths. I love this. Okay, what can I strengthen? Not what's my problem, what's I'm going to improve. What am I going to strengthen? And that's really a thing. So this is just a little website you can go to later and hopefully do it. The biggest thing that also I want to highlight before I get into the examples was the health disparities, the co-occurrence of all of the medical and mental health substance use and in the interactions of maybe two or three of these areas. Again, the adverse health outcomes in the United States, that data really drove the acceptance of this model here. And I think many people are seeing this model around. It's not new, but again, to frame it in how it affects a lot of these social determinants of health, those risk factors, the socioeconomic status, the adverse life experiences, the trauma, as well as, just stress and the chronic, I just started working so many more times with people who were just, again, I've experienced a little bit of it, but again, so many people dealing with stigma and discrimination, the development of the poor habits, the stress that people are living. And then again, this was another one that became focused, was the shortened lifespan, but it was about here, the lack of access to quality, timely, preventative care and primary care behavioral health integration. So the model, again, it also helps to understand the social determinants of health. As mentioned, it affects, I think really it's a big piece of it that's been appealed, that especially as it developed the financial and the occupational and environmental dimension that I've been working with on a number of projects. So it's the physical one was the big one that we really started to focus in on, that got this model out there, and you can see it, interactional effects. They all affect each other in different ways, and each of you, each of us, each of the people we serve will be in different ways how it affects. But I knew sleep for me paramount in my day, and it definitely gets messed up at times, and it's just paying attention to that. It's not necessarily just a pill, it's focusing on that sleep piece for me, and many other things like that can help, as well as so many other things. But just to get to understand some of the things that the model has developed, I want to go here, was wellness coaching became one of the first things, the peer-led wellness coaching. Just gave you a few examples of articles you can link to, but this role of peers. So I developed over time many self-help tools I can share. Wellness coaching model in about 2009 to 11, we developed an intervention. I don't even call it an intervention because it's a peer-to-peer model of doing wellness coaching, and a number of my colleagues and I have developed a variety of studies since using this coaching approach for peer providers. It's a training that's offered for peer support providers to help people around health habits. And it's interesting, this model got so popular, which was funny, that behavioral health managed care companies had hired us to evolve the training for their case managers. So it really started to, from the peer model, we had to tweak it a little bit, but we actually train now in case managements to use this model, the strength-based wellness model, and especially in these integrated care programs that in the United States, a lot of them came about in the previous presidential administrations, that there was a lot of focus on health disparities during that time, 2008 to 2016. We developed a lot of these health models. So the wellness coaching was one, and we have a couple of other studies on that. And the other thing we did, and this was about 2006 or 7 or 8, I started just doing health fairs at peer programs. We started to just go in, do blood pressures, help people to start looking at some of the health risk factors when we were having big gatherings of people in recovery events. And eventually I evolved it into a health fair model, started to involve some nurses and some other healthcare providers, and then eventually started working with University of Illinois Chicago, where we got a National Institute on Disability and Independent Living grant to actually do a series of health cares in a couple of states, and we gathered some data. And we also created a guide for developing a successful health fair that was really peer developed, peer delivered. All of this stuff that I'm showing here is all in public domain. The toolkits and things you can access on some of the links. So that was a really nice outgrowth, one of the peer developed programs. We worked closely with UIC, University of Illinois, And what I do is in my role, I wear like two hats. I'm at the university, and even during this time, I was much more at the collaborative support programs in New Jersey, the peer run agency. I really just brought to their table people in recovery to help do this, the health fairs, to help plan the health fairs, to help analyze the data. We were really involved in a co-produced manner, a collaborative manner with the whole all of the research project, and actually doing the health fairs, and gathered some data. We have a series of papers on that. Our most immediate project, which is really interesting because timely, is enhancing your immune health. So we started working on this like about maybe a year ago or so or less, maybe to develop a peer to, it can be, it's designed to be peer delivered, but doesn't have to be, enhancing your immune health. So we created modules that were used to help understand your immune system and what you can do for your health, the sleep, the stress, being able to really understand really crappy information that's out there that's probably not right. It's like really helping people to understand how to use good health literacy skills around, like, these things that you see that are outrageous about people's, what we do for our immune system, or we can just take this pill or whatever. But no, it's what you can do in your life, and then understanding health literacy. And we really did this in a co-produced manner and tried to like help get people. There's some materials. Here's the manual, the module outline. And again, this is up on this website too as well. We actually developed this. We haven't like fully tested it because we wanted to just get it out there. I'm currently working with, I trained peer champions who are working through our large supportive housing, peer-run centers, and we run some peer-run respites. They're actually using it in those sites, just trying to see how it works and get feedback to help inform some improvements in the manual, and then we'll do a little bit more research. We just felt this was such an important topic right now, the development we needed to get moving forward with. Where you can find a lot of this and many other tools around wellness that I have is on a solution suite for health and recovery. This became part of this collaborative that I did with University of Illinois, Chicago. And they basically, we have things that are free, that can be delivered at minimal or no cost. We've manualized different resources. And we also found things that were out there already, because I have a lot of things and some of them are up there, but there's so many other things out there. So we curate them, try to put them up there and help them to be, used and we can provide some modest technical assistance with that. I'll just give you a little bit of a taste. It's called the there's a section on integrated health and mental health care and self-directed recovery. So there's two different sections that it's divided up to. And the materials that I highlighted in here are the ones, they're a little more bold, are the ones that our group developed more of a lead with. We've been involved in the others, but we were more of a lead in the activities manual, the wellness in the 8 dimensions and activity plan. That's actually something that has been around since 2009, and we just developed it. It's just more of a self-help tool for people. There's the promoting wellness for people that I mentioned previous, and we have a physical wellness for work. Again, thinking about all those dimensions this hits, and a journaling tool. In addition, I know just with time, I want to be able to, the self-directed tools, the one that we have contributed the most to on that one is the Building Financial Wellness. It's a curriculum, and I'll show you in a minute. But then there's some other ones. This just gives you an idea about supported employment, raising difficult issues with your service provider, a variety of different topics in their little, there's resources on them, the manual, there's a podcast to listen to, it's short, and then there's a sort of a how-to webinar type thing if you want to start, giving you more guidance on using it. The other thing, the financial wellness, I did want to mention just before I, as one of the things, and I know that, we'll take some questions later, is that this one was so important. We developed this one really, oh, oops, sorry about that. So the financial, oops, which, oh boy, something happened here. It's 6 weekly sessions focused on individualized skill development. There's in-class and preparation, between times. And it's really, there's a facilitator guide on there and then a participant guide. So you can access this right now. We did the pilot testing of that, and that actually we're in the probably 3/4 of the way of a randomized control study of this project that the data on that should be available. But again, we just like to get this stuff out there beforehand to start to, because it has been developed much with people's feedback, get it out there. And again, some of the data will start to be out there a little bit more. And here are the topics of that. And this curriculum is just amazing for people. And most of the people are extremely poor. They're on entitlements, or they're trying to get off of the entitlements. And you should see that people who are in poverty, people who are living, can save, can transcend that poverty trap. And again, this curriculum has been so empowering for so many people. I do want to just kind of I have so many more things to say and share, but I did give quite a bit of there's way more things I could share, but I just wanted to give you the little bit of the background about the model, as well as just to highlight a few of the co-produced tools that we have developed, and some of our process for, trying to get them out there, and, then starting to test them as we go along. We develop them, then we feel it strongly to get some of this stuff out there, get the field feedback, and then perhaps go back and do a little bit more scrutiny in more detail. But love to hear the comments and feedback later on. But please feel free to just want to see how the wellness model started to frame a number of these important projects for people here. And again, you can access them worldwide. They're on that website, and we try to make everything free and accessible to people.
Thank you, Peggy. That was really interesting and affirming. And the way we've set up the seminar is to have questions, a sort of Q&A session at the end. I think that our next speaker, Amanda, there might be some quite interesting overlaps as well with some of the work you've done, particularly around, her stuff's quite specific, but maybe around some of the sort of peer support end of things. So are you there, Amanda? I can't see anyone. I hate Teams. There you are. Excellent. So Amanda is peer support lead for NSFT. She was part of the original team who founded the Recovery College, and not just Recovery College, actually, Amanda, peer support work and other IMROC challenges in NSFT, and has co-produced many Recovery College courses, including wellness planning and safety planning. So Amanda is a member of the International Peer Leaders Network and campaigns for better service user and carer involvement. She gained a master's degree in mental health recovery and social inclusion from the University of Hertfordshire, and is currently undertaking a PhD for her sins with Mary Leamy and Alan Simpson at King's College London. And so you're talking today about your PhD studies, or part of your PhD studies. So I'll let you begin, if that's okay.
Thank you. I'm just going to see if I can share screen. It worked earlier, so let's see. You'll have to let me know if that's working.
Yes.
Good. I can only see you, Karina, so you'll have to respond.
I'll keep smiling.
So yes, so I'm currently a part-time PhD student with King's College London, and thought I'd talk to you today about, if I move on, you'll see my next slide, why I'm researching. So I'm currently researching the Recovery College Safety Planning course, talking about how I use my lived experience in my research, how I'm doing my research, and how people can get involved. So safety planning and me. So what am I doing? I often ask myself that. I never in my wildest imagination dreamed that I would be here, that I'd be working in mental health, let alone doing a PhD in it and researching mental health. It's wasn't part of my job plan, wasn't part of my life. I was actually an actor and a theatre director. So how did I find myself here? Well, it's been quite a journey. It started with a depression, a suicide attempt, and contact with mental health services. It took me through many diagnoses, many suicide attempts, years of acts of self-harm, and a lot of contact with mental health care, being sectioned, spending months and months on psychiatric wards, long periods under community mental health teams, day services, supported living accommodation, and finally interpersonal recovery. As Karina said, I was one of the people who helped to establish the Recovery College in NSFT, and for which I've co-produced many courses, including wellness planning and safety planning. So why safety planning? Because I noticed many things. In particular, I noticed that there was a direct correlation between how I was related to and understood within mental health services and how my risks were managed, and an escalation in my risk behaviours. And I also noticed that the opposite was true. I noticed that there was a direct correlation between an increase in my personal recovery, my understanding of what recovery meant to me, and a decrease in my risk behaviours, in my impulsivity, in my acts of self-harm, and in my suicidality. But first, what do we mean by safety planning? Well, safety planning is a recovery-oriented, collaborative approach to managing risk. It's based philosophically on person-centered care, on recovery-focused and shared decision-making. We didn't invent it. Health policy in the UK positioned mental health within a recovery-oriented framework in 2011 and 2007. Best practice guidance for risk management from the Department of Health says that risk management within mental health services should be done collaborating with service users in the assessment and safety planning process, and a widening of the risk construct beyond dramatic risks. So not just focusing on my acts of self-harm or my acts of suicide, but to include positive or therapeutic risk. So promoting a person's autonomy and control and building on strengths and protective factors. So what do we know about safety planning so far? So research into safety planning, despite best practice guidance around a recovery-oriented approach to risk, which identifies a number of key factors for effective risk assessment and safety planning processes, there actually is very limited research on safety planning in general. In particular, there's a lack of a standardized definition. There's no widely accepted standard model that provides a basis for systematic training. There is virtually nothing written on standards of care for safety planning, guidelines for practice, or even careful descriptions of its major components. The literature that is available shows a lack of consistency, a variation in research methods, and constraints in practice settings. Results from 2 studies also suggest that there is minimal formal training and little ongoing systematic supervision for safety planning. So there's a lot of research that needs to be done into safety planning in a wide range of contexts. So what do I want to know about the Safety Planning Recovery College course in NSFT? Well, the obvious question to ask would be, does it work? I don't need to do any research to answer that question. Does safety planning work? Yes and no. It works for me. I need to put it bluntly, I don't think I would be alive were it not for safety planning. It works for other people, yes. I know that because they've told me. Service users, carers, staff members who've done the course tells me it works. And service users, carers and staff members who've done the course tells me it hasn't worked. It's not changed their behaviours. It's not changed their risk management behaviours. It's not worked. So then, does it work isn't really the right question. This does, though, tend to be the question of traditional evaluations, which attempt to provide an estimate of programme effectiveness through assessment of one or more outcomes. This would give us effect sizes. It would tell me that the safety planning course helped more people than it harmed in the time and place in which it was delivered, but it would tell me very little regarding how it interacts with social context to produce its various outcomes To do this, we must go beyond simply asking, does it work, to a much more nuanced question. How does the safety planning course work for whom, in what circumstances, and why? So whether the safety planning course achieves its intended outcomes is not simply a question of the quality of the resources in the training, but is also dependent on the individuals, interpersonal relationships, the institution of the Recovery College and its infrastructure, the organisation and context of NSFT and an NHS organisation trust, as well as wider cultural and socio and political contexts. Attempts to measure whether it works will be of little use if they fail to provide logical explanations as to why it sometimes works and sometimes does not, or in what circumstances or conditions it is less or more likely to work, or what can be done to maximise the chances of its being successful. See, we know it both works and doesn't work, but what we don't know is what's the difference. Why does it work for some people and not for others? The latest guidance from the UK Medical Research Council for developing and evaluating complex interventions, which was published earlier this year, recognises the importance of understanding how contextual factors influence health interventions. This type of evaluation is increasingly being used by academics, practitioners, and policymakers within the health field, and is known as realist evaluation. This was first developed in the UK by Pawson and Tilley, and it's a theory-driven approach that examines not only outcome, but also the possible causes and contextual factors associated with change. The core principle of realist evaluation is to make explicit, so to make known, the underlying assumptions about how an intervention is supposed to work, known as program theory, and then gather information in a systematic way to test and refine this theory. So this is my study design. It's quite a complicated study design. It's iterative and it's sequential, so it'll kind of go in different phases and go across these phases. At the moment, I'm in phase 1, theory development, and I'll talk more about that in a moment. And then I've got phase 2, which is theory testing, and then phase 3, which is actually describing evidence-based theory. So this is the phase that I'm in at the moment. I'm in phase 1, which is developing the initial program theories that describe how the program architects, so that's just realist evaluation language for the co-producers of the course, how the people who co-produce the course, the safety planning course, intended it to work. So I'm collecting data in 2 ways. I'm doing an auto-ethnographic layered account and then a qualitative in-depth email interview. So what's auto-ethnographic layered account? I am writing an auto-ethnographic layered account about my experience of risk management while a service user of mental health services and the reasonings and the meaning making that led to the co-production of the safety planning course and the development of its key resources. An auto-ethnographic layered account is one that shows connections between personal experience, theory and research practices. This is where, as a lived experience researcher, I bring my understandings, knowledge and point of view to the research. Autoethnography. It recognises the innumerable ways personal experience influences the research process. It acknowledges and accommodates subjectivity, emotionality, and the researcher's influence on the research, rather than hiding from these matters or assuming they don't exist. It is increasingly becoming a popular form of qualitative research, although it is not without its critics and controversy. But as a peer support worker, I'm very used to critics and controversy. After all, it is a form of research that is challenging existing power relations between users and providers of health services, which sounds rather familiar as a peer support worker working in health services, doesn't it? As autoethnographic authors, we frame our accounts with personal, reflexive views of ourselves. Our data is situated within our personal experience and sense-making. We ourselves form part of the representational processes in which we are engaging, and we're part of the story we're telling. It's a truly transformative process that impacts on my own beliefs, actions, and even my sense of self. Every insight I gain is both a mirror and a doorway, a way to look at my own experiences, increase my personal safety behaviours and skills, my safety planning processes, if you like, as well as a way of seeing into other people's struggles and experiences. And there is a balance. As you may imagine, it can also be quite self-absorbing and self-indulgent. I'm not writing an autobiography. I have to keep in mind my purpose in writing, which is to develop, as one of the co-producers of the safety planning course, my goal is to use my autoethnographic writing to develop initial program theories about how I think the safety planning course might work. And these will then be tested and refined throughout the rest of the study. So once I've finished my autoethnographic sections, I will then interview Sarah Kennard, who was the person that I co-produced the safety planning course with. She's a mental health, she's a social worker actually. She's in the trust. She still works as Recovery College lead over at Great Yarmouth and Waveney. And I'll interview her and then gather her understandings on how she thinks the safety planning course thinks that the safety planning course works. Once we've written those, they will be written as initial program theories, and we will then go into phase 2, which will be the theory testing. The aim of which is to develop evidence-informed program theories which explain how the safety planning course works, for whom and in what circumstances. Here we'll do a realist review of the literature and some qualitative in-depth email participant interviews. Oh, I've gone backwards. Don't go backwards. Participant interviews. So these I will be looking at recruiting. Don't rush to do it because I'm still in phase 1. But I will be looking at interviewing peer tutors and staff tutors, so people who are currently or have delivered, facilitated the safety planning course. I'll be wanting to look at service users, carers, family members or friends, and mental health professionals who have attended the safety planning course as students. And I'll also be wanting to interview stakeholders who haven't attended the course, but perhaps have some responsibility for risk management, patient safety, or implementing safety planning policy in NSFT. As I said, don't get too excited. I will be recruiting that probably in a couple of years. I've got about another year on my autoethnography and phase 1 of the project. But I will keep you posted and let you know. You can get involved before then, and I'll tell you how in a minute. So once we've done all that lovely stuff, we'll then go into phase 3, which will be actually producing evidence-based theory, which will describe a logical understanding of what aspects of the safety planning course work, how, for whom, and in what circumstances. And I will use those to make some initial recommendations, perhaps about how we can improve the effectiveness of the course. Maybe it's going to require a bit of co-design, bit of change, a bit of growth, or how it may be implemented within different settings, different contexts, different Recovery College courses, perhaps. So how am I going to analyse all this lovely data that I'm collecting? I'm using something called reflexive thematic analysis. Realist analysis takes an iterative approach, so that moves between different sources of data and uses deductive, which means making an inference, making a kind of theory based on an observation. No, sorry, deductive based on widely accepted facts or premises, and inductive, which is making the inference, making the kind of theory based on observation. So it uses both of those kinds of reasoning within realistic analysis. And throughout every phase of the study, I will do that using reflexive thematic analysis, which was developed by Braun and Clark. Reflexive thematic analysis is suited to experiential, so critical realist framings of language, data and meaning. It embraces qualitative research values, the subjectivity of the researcher, and is situated as an interpretive reflexive process, which invites creativity and innovation. Coding process is integral to theme development, and the themes will be used to develop the program theories, which will answer my research question. How does the safety planning course work for whom, in what circumstances, and why? So I said you could get involved. So I'm currently recruiting an advisory group, PPI. Group members will be people with lived and learned experience of safety planning. They will be asked for their input, thoughts, reflections at kind of key points of the study, including designing material for recruitment of the interview participants, and discussing, reflecting, giving me thoughts about emerging key themes and program theories as we go along. I'm looking for people with lived and learned experience of safety planning. Why? Because a wide range of different kinds of knowledge in advisory groups has really been found to add scientific value and maintain research integrity. And I think it will probably improve the quality and the relevance. Thank you. If I can stop. How do I stop presenting?
Well done.
There we go.
Okay. That was really interesting. Thank you, Amanda. I think it's such an interesting and important project, and also it's really helpfully described realist methods, which will help Sarah and I in the next talk. So thank you, and yeah, some kind of common humanity between you and Peggy, I think, around personal recovery, and just I think the way we think about research and the sort of maybe slightly more applied methods that we use to really, which I think can feel slightly different than kind of that kind of usual academic, more kind of research, that the applied research feels a bit more nuanced, a bit kind of not messier because it's still quite robust and systematic, but better reflective, I think, of people's journeys as well, in terms of thinking about how things work, why they work, and for who they work, and then some of the, so everybody's commenting, which is great. So that's fantastic. And what we'll do then is we'll hold questions maybe for a more kind of involved discussion between the whole panel at the end. I froze, didn't I? At the point I was still rambling. I did. Okay, so I'm going to push through. So Sarah Ray, I can't see you, Sarah. Are you there? If you unmute yourself, you'll probably pop up. Can you see her on participants, Bonnie?
I can't see anything at the moment. I managed to unmute myself without thinking about it. So,
oh, well done. That's smooth. Okay.
No, she's gone. I'll get her. Try and get her back in.
Yeah. Okay. And her and I obviously had similar network issues at the same moment.
Yeah.
Should we move to a couple of questions then for Peggy and Amanda while we're waiting for Sarah to hopefully rejoin?
Just making sure Peggy's around.
I can see Peggy.
Peggy's here. I can see Peggy now.
And Amanda. So either people can unmute themselves or put questions in the chat if there's anything, or comments. And I noticed that, Bonnie, you've put the quiz in the chat, haven't you? The link.
I put the quiz link. I didn't know if that was helpful, Peggy. I also thought having a play of it in between and horrified by what the
No.
what my school was coming out to me.
On the wellness quiz, yeah.
Apparently sitting at your desk for 12 hours a day every day isn't the way to go.
No, who knew?
So,
so has anybody got a question they want to put their hands up or?
We stun them into silence.
Stun them always. I had a question. I think probably for Peggy, although I can't see you now, Peggy.
Yeah. I'm trying to the cameras have to think, but I'm here.
You're there. Okay. I wanted to know about how we can how people can be empowered to become peer researchers, or what kind of conditions are needed for people to participate in research, and then maybe be upskilled towards leading their own research projects, and what are the important things to consider? So is it about training? Is it about kind of thinking about people's own personal journeys and career progression, payment, or all of the above? So I wondered if you could talk to us about.
Yeah. Well, we've I work with people across life, different experiences, people who might be thinking about going back to school or career path, and then people, we work with a lot of people who've actually been part of the system for many years, and they're just happy to be part of research when people are. I'm like a big bridge between like different universities. I'm at Rutgers, but I do a lot of collaborations around the country, and even now with Karina and Bonnie and others, to try to help people get involved and just be part of being asked questions, just really going into local communities, getting the feedback, immersing ourselves as researchers or policymakers or people who are trying to develop this, and then start to create many opportunities, create career paths for people. I've done a lot of work around helping just people get involved in the study, planning the study, training them again, getting them trained in this IRB. Like that's a huge thing. Like we have people run away from the IRB certificate, that we have the training that they have to do, but it becomes a learning curve for people, but it also becomes a way we mentor them and get them more involved. And we have a number of people who actually have gone to graduate school and become involved over these decades. But I think it's just finding all different ways to reach out, that it's not just, and then providing career paths for people, for sure, and finding ways to fund that. Just recently at our agency, we did a fundraiser to actually fund monies to help people move back into school and, try to help people go into research, go into the field because I think Amanda just talked. I love the way you just brought so much of that. It's so important that we have people who've been on the other, who've been on this other side of it there to have that voice. Back in my day, I could not talk about that early on when I was versed as an occupational therapist. I had to be really undercover for years in my work. And then eventually, as I got my degrees and started to be more, I could speak out more. And then people start to oh, wow. And you had that horrible, but you have this degree. Sometimes I get mad about that. I'd be like, my experience is even more than this degree that I have, but again, it's giving people the opportunity to be at the table and finding all different ways to support people, but just really going in and involving people in any ways you can think about it. We've done that. And again, you can see we're very practical matter. I could go into some more research things, but I wanted to share a lot of the practical things that we try to have hit the streets quick to make people really get accessible tools, and them being involved in that there, and people just it helps their recovery. And again, it might help their career path.
Great, thank you. And Bonnie, you've got your hand up.
I do. It was to follow on actually on from what Peggy just said. There was a question for Amanda, which is that you're being supervised by people at KCL and national experts. A lot of people feel quite intimidated starting that process. I just wanted for you to kind of just reflect for everybody kind of what your experience or what your perceptions are of that process of just getting that first step on the ladder of using your experience to get into the PhD, how that worked. I think would just be interesting.
Yes, I'm still intimidated by that process. I think I still feel like a complete imposter, and kind of sit there going, what am I doing? I don't know what I'm doing. I was really lucky in that I'd met Mary Leamy when I was presenting my master's at a recovery research network meeting, and I kind of met her in that context. So then when I was looking at, you know, who I want to do a PhD with, I very much went looking to where she was, and she happened to be at King's College London, and approached her on that kind of basis. I think it's stepping into these kind of different worlds it is daunting. I had many conversations. Luckily, I had Karina in the background as my cheerleader, and I was going, I'm writing my application, and she was going, have you got it in yet? And I was like, no. And I think you need that. You need people kind of in your corner who are spurring you on. And I guess that when you've been understood as mentally ill and that kind of pathologizing for a long time, I feel like I've wasted 10 years of my life doing that. You know, I wasted 10 years of my life being stuck effectively. And you get to a stage where you go, if I want life to change or I want things to happen, I'm just going to have to go for it. So you have to be a little bit brave. But I certainly wouldn't like to say that I don't feel like a fish out of water. I do. I do. King's is quite a daunting place. Mary Leamy, for those of you that don't know, is the person who led on the research that developed the CHIME recovery framework. So really important piece of research for those of us who work as peer support workers within kind of recovery models. So yes, don't know if that answers it, but it's scary. But it's scary, but do it, is what I would say.
Lovely. Thank you very, very much for that. Thank you.
So Sarah, you're back. Hooray. I think we might have lost you for a moment, which was always the worry, wasn't it?
It was the worry, despite us road testing it yesterday, but I did, yes. I had to restart my computer. That's the problem, to get back on again. So, however, I can hear my husband's just walked in, and he is sort of technical support, so.
Good. So your technical support is there, should it be required?
Well, he does say he doesn't know what to do about it, but we'll see. He's certainly got a better chance of solving the problem than I have.
Okay,
So
well, fingers crossed they won't be
drops
more.
again, that's what it is.
Okay, well, we'll press on to your talk. So just to introduce you, Sarah. So Sarah is determined to influence the design and delivery of services. Her involvement with quality improvement initiatives led her to join the Health Foundation's Q community in 2012. Sarah was non-executive director of the NIHR Applied Research Collaboration, ARC, East of England, from 2011 to 2019, where her role was to champion patient and public involvement, or PPI. She's worked with the Eastern Academic Health Sciences Network on mental health-related projects and is a member of the East of England Citizen Senate. Sarah sat on the Board of Trustees at National Mind from 2011 to 2020. Following the publication of Mind's Crisis Care Report, she co-founded Promise in 2013. This 3-year quality improvement programme significantly reduced the use of physical interventions within the Cambridgeshire and Peterborough Foundation Trust. So that's a really good example of things actually working. Over the last 2 years, Sarah's contributed as a lay member to the NICE Guidelines Committee, which is responsible for revising and updating guidance on self-harm. So you and Amanda probably have some juicy conversations there, I should imagine. Sarah is currently the service user consultant for the Safety and Mental Health Settings Project. This is a pan-London project focusing on addressing issues of violence and aggression within acute care and psychiatric intensive care units and supporting staff skills development. So another very impressive CV. Sarah is currently co-lead on Minds. Thank you. This is great for us. And this is a research study which is funded, yes, by the National Institute for Health Research. And that's what Sarah's going to be talking about today. And then I'll be contributing some slides in the middle about the kind of study design that we're undertaking for Minds. So I'll share the slide, shall I, Sarah?
Yeah, that would be absolutely great.
Okay, here we go. This is where
I can't multitask.
Horribly wrong. No, nor can I. So hopefully, let me see if I can get it onto slideshow. Should be able to do that, shouldn't I? Oh, it's right there, isn't it? It's amazing how your brain just stops when you're in public, but there we go. So can you see that?
Yeah, I can see that. Yeah.
Good.
And it's amazing
Hopefully
how
everyone else
your anxiety can shoot up when your computer doesn't behave. Okay, so as Karina said, I'm Sarah Ray, and it's the first slide still, Karina. Yeah.
Oh, sorry.
Yeah, just going back, just introduce. And today in my part of the presentation, I'm going to be talking about the inception of the MIND study, our patient and public involvement or PPI work, and then move on to talking about the value and challenges of co-producing healthcare research. Could I have the next slide, please? So I have experienced emotional dysregulation and mental health and mental distress, actually from as far back as I can remember. But my condition wasn't really diagnosed until early adulthood. However, it was only after I'd spent 8 months on an acute care unit in 2005 that I became motivated to train as an expert by experience. And that course was really a stepping stone to involvement in healthcare research and quality improvement initiatives, which included roles, as Karina just mentioned, such as working as a lay public and patient involvement advisor to the East of England Applied Research Collaborations, to their board, and also as a trustee of National Mind. So in short, I became an expert by experience with teeth. And so by 2013, I really had the confidence, but I started off at a very sort of low point confidence-wise, to challenge the clinical director at my local trust about what was being done to reduce the use of restrictive practices. And it was during our first meeting, actually, that the project Promise was conceived. And that resulted in me co-leading that successful program for 3 years. Could I have the next slide? So the title of our study is Co-Producing Improved Mental Health Acute Inpatient Discharge Using a Systems Approach, or the MIND study. And the aim is to understand discharge planning as a complex intervention within complex systems to co-produce systemic discharge care approach, or SCDA. The MIND study will evaluate the implementation and cost impact of the SDCA ready for a future hybrid type 2 trial. Could we move on to the next slide, please? So this is in terms of just saying a little bit about my personal drivers. So it was my negative experience of being an inpatient, which left me with that strong desire to influence the design and delivery of services. Because I found the discharge process in 2005 even more traumatic than it had been when I was discharged as a young adult from a therapeutic community. It was horrendous in terms of the stress and anxiety it caused me, and that led to serious self-harming behaviours. So the other reason I was very keen to get involved and do something proactive about improving the discharge process was because through my work, I work with a large number actually of people with lived experience, experts by experience, and I quickly learned that actually poorly planned discharges were not uncommon. And it was confirmed, in fact, when MIND published their Leaving Hospital survey in 2017. And the findings from the report strongly resonated with me because they mirrored well, not all the findings, the majority of the findings mirrored my own distressing experiences. Could I have the next slide, please? So this is just to give you some headline news from the MIND's Leaving Hospital survey. I'm not going to read through it, except that I think it's important to note that the NICE guidance says to give 48 hours notice of discharge to patients, but a third of the respondents in the survey received less than that, and 1 in 5 was given no notice at all. Could I have the next slide, please? So it's very confusing here because I'm talking about mind and minds. So moving back to the mind study, and also thinking about NICE guidance and mental health legislation, which they recommend that discharge planning should be person-centred and collaborative, but it's really not clear how this should be achieved and how the emotional and psychological need for this reason, the emotional and psychological needs of service users are often overlooked. So it's the MIND study aims to bridge this knowledge gap. Could I have the next slide? Great. So for me, I've had these bad experiences when I was discharged on 2 occasions, but it was the MIND survey, I suppose, that really, the findings from that survey that really acted as a catalyst. And by 2018, I'd started sort of floating ideas with MIND staff, with researchers, about ways to improve discharge experiences and outcomes for patients. And I also contacted colleagues at the East of England's Research and Design Service about the sort of feasibility side of conducting the study. When we started out in the early days, it was quite a long period where there was a lack of clarity about the scope and the focus of the research. And so to progress the project, I invited one of the engineers from the Engineering Design Centre at the University of Cambridge to talk to the team, it was only a small team in those days, about a systems approach to healthcare. I knew this researcher, I knew he was a proponent of PPI, and that we had a good rapport because I'd worked on another project with him. And his presentation was actually a light bulb moment for the team. And the excitement was palpable, you know, it just changed the whole dynamic. The identifying of the right clinical co-lead was fraught with difficulty for me. And it resulted in a very hasty decision to recruit someone who turned out to be unsuitable. I'll say a little bit more about that later. Could I have the next slide, please? So, yeah, now I want to just hone in a bit on the public and patient involvement work we've done for the MIND study. So I led on this aspect of the work because I was so keen to ensure that there was meaningful PPI from the outset. So to inform our phase 1 application, as you can see, we consulted with both staff and service users. And for the phase 2 application, we did a bit more PPI work because we realised that perhaps the people that we've spoken to had come from weren't particularly representative demographically. So we wanted to ensure that we captured the views of people from more diverse backgrounds. So we worked with, we went out to our partner trust in London and talked to people who regularly got involved with that trust sort of PPI through their PPI network. Could I have the next slide? So I don't really have time. I could talk in depth, but I don't have time to talk in depth about the findings from our extensive PPI work. And so, for example, we talked to quite a lot of staff as well, but and I can't go into talking about the staff perspective. But I just wanted to highlight some of the key findings from our service user survey. The reason we conducted our own national survey, which was to learn about more recent experiences of discharge, because although we had the MIND report findings, that was 2017, and by this time it was about 2019-20. So we wanted to capture, because things change so quickly on the ground, that we wanted to capture those recent experiences. And also we had some slightly different questions we wanted to ask. And I put in a huge amount of hard graft promoting that survey, which had been reviewed by experts by experience, and gratifyingly, it was completed by 120 respondents, which I was quite chuffed about. So people reported poor experiences of discharge, leaving them feeling overwhelmed and ill-prepared for leaving hospital. In particular, over 50% had little or no involvement in discharge planning, and only 17% felt very involved. 52% had a discussion about discharge towards the end of their admission, but for 46% of respondents, this only happened either immediately before they left hospital or not at all. And the last slide that I'm going to talk to you for a moment is this one, which has just really got some quotes on it that will give you a few seconds to read. But yeah, this was just the tip of the iceberg, really. I mean, we heard some really worrying stories from people about how they'd been, you know, or how unhelpful the discharge planning process had been if it had been in place at all. Now I think I'm going to hand over to Karina.
Thank you, Sarah. I'll hand back to you in a minute. So I was just going to quickly talk through the methods involved in the MIND project, because I've been quite heavily involved in thinking about how we answer our research questions methodologically. And as I mentioned earlier, after Amanda and Peggy's talk, these kind of methods that we use have to think about and replicate kind of the applied systems that we're working in. So we know from what Sarah said that there's been quite a lot of empirical work actually around discharge, and as Sarah mentioned, that therefore there are nice guidance or nice guidelines around how discharge should be how it should be delivered by services, but as she mentioned, it's not clear in terms of how, and I think that that's possibly some of the problem in terms of people's kind of continuing poor experience of being discharged from hospital. I think that comes down to quite a lot to do with the way that the kind of cultures on wards and the way that staff are working and the way that they are or aren't supported to work in collaborative ways, and also comes down to kind of much more wider systemic pressures around that bit of service delivery. So what we wanted to do with the MINDS project was think in much more systemic ways about what good discharge looks like, what are service user requirements for discharge, and then think about how those might be met through kind of co-design and co-production of thinking not about necessarily training programs or toolkits, although that might be what comes out of this, but thinking much more about a sort of systemic discharge approach. And so these pictures here are one of them, the figure A came from the Engineering Better Care manuals, which I think Sarah was mentioning Alex Kamashi, who is our brilliant Cambridge academic, who's a healthcare engineer, and John Clarkson have worked together to produce a toolkit around how to engineer better care. And that really recognises that one of the most important layers of the system is the staff, or the interpersonal relationships between service user and other parts of the system. And that's also then reflected in our kind of gobstopper model of different layers of the system that we're going to try to consider in this piece of work. And then, as I mentioned, I was very grateful to Amanda, who took time and was very clear in terms of thinking and explaining what realist methods are. So realist methods have some central questions around what works for who, in what circumstances, and how. And this is really in terms of understanding programs in care and mental health care in ways that reflect the complexity and the kind of complex systems and complex needs, complex relationships that are involved in delivering care. So much like Amanda's project, the first work package of the MINDS programme will be developing programme theory to think about discharge, to think about who's being discharged, the kind of factors that impact their experience and their outcomes, but also a lot of work on thinking about staff side. So there's a brilliant research nurse called Joy Bray who's on the team, who's worked on the wards for many years as a nurse, and who has really helped us to think about issues on the nursing and the staffing side that get in the way of collaborative and person-centred discharge experience. So we'll bring all of that together along with a wealth of literature around discharge to think about how to develop some kind of complex theory. That theory will then be boiled down into people's requirements for discharge. We'll be doing some work with service users and staff to prioritise those requirements for discharge. And then we'll take the programme theory and those requirements to work package 2 or phase 2, which is where we'll be working with our lovely Cambridge engineering colleagues to co-design with experts by experience, service users, carers, staff and other kind of key stakeholders, a more systemic kind of approach to thinking about discharge that factors in and balances the needs of both service users and staff to think about how it could be more collaborative and more person-centred. And part of the reason why we love working with our engineering colleagues is we've got no idea what that's going to look like or involve at this stage. We're hoping it'll be something a bit different from what's been produced before. There's been mention of robots, origami, who knows what else, but so we're hoping that we'll come up with something quite innovative in our work package 2, where we'll be undertaking co-design workshops with people. And then lastly, in our last phase of the research, we'll be evaluating whatever we come out of work package 2 with. So we'll be trying it in practice on the wards. So this piece of research involves 3 mental health trusts and 6 wards as individual case studies for the research, and we'll look at evaluating the implementation of it. We'll look at resource implications and cost implications of using it to determine feasibility, and then we will be trying it out and doing more observations, ward-based observations and interviews, as well as collecting some initial outcome measures, more around sort of feasibility of using those outcome measures. And this will be firstly used to refine the programme that we come up with, the systemic discharge approach that we're trying to develop, but then we'll then take that refined discharge approach to apply for further funding to do probably an RCT. So hybrid type 2 just means a kind of complex, fancy, applied trial to see how it works in practice. And as Amanda was saying earlier, that we already will have answered those fundamental questions about who it might work for, but also critically how it works. And so what we want to do in the research, both in this bit and in the trial, is not move away from those important applied questions about how it works and who it is and isn't working for. So we'll carry that into whatever trial we do next. So back to you, Sarah.
Yes, well, luckily I'm still here.
It's a good start.
It is a good start, isn't it? So I'm going to move on now to talking a bit more about the value of co-production in healthcare research. So I think with reference to the project initiation and development, the benefits really included that robust PPI, which informed the proposal development from the outset. I'm going to take a bit of credit here because I think it was partly because I was responsible for this area of work, and it was actually commended by the NIHR reviewers. Co-production and involvement of patients is embedded throughout the project. So, for example, not only will we have a lived experience advisory group, but each work package will be co-led by a researcher with lived experience of discharge. And I think, quite importantly, more recent experience of discharge than I have, because mine was back in 2005, and that's, you know, things have changed a lot since then. And equal partnership working has really, I think, in this in the project team, we've got a really level playing field, which is something that I'm really pleased about. It makes it, well, I feel much more confident when there's a level playing field. And if I could have the next slide, please. And then in terms of new perspectives and team building, I think lay co-leads often have different drivers. So, for example, I am much less interested, in fact, I have no interest really in authoring academic or co-authoring academic publications in high impact journals. And I'm also not constrained by sort of institutional structures and requirements. So my priority is actually to see change on the ground for patients. I'm also a non-conventional voice within the team. I think I do have some ideas that are slightly outside the box. So, for example, I had the, as I've been working on a NICE guideline committee, I immediately thought about the possibility, we've explored the possibility of NICE endorsement, for example. And then the fusion of that research and clinical expertise with a lived experience perspective adds an extra dimension, which I believe is greater than the sum of its parts. From my experience, also co-production fosters that sort of reciprocal relationship between different stakeholders, particularly if the co-leads are modelling good practice and leading by example. And then having strong team relationships built on trust and effective communication is key if you want to allow that room for challenge and for people to feel open to challenge and question. I think that's another important aspect. Can I have the next slide, please? Okay, another slide on the value. So I also really believe that co-production supports robust research delivery and outcomes because it's challenging. It is challenging traditional power structures and or cultural barriers. It's more likely, to generate accessible outputs. For example, the study findings will be available to patients because while through Mind is just one way, because they're supporting our bid, but obviously we'll try and ensure that patients, there are many different ways that patients can learn about the research findings. And I also feel it's really important that frontline ward staff get to know about research through nursing journals, which I don't feel happens often enough. And then, of course, it delivers research which is more relevant to the needs of service users and has greater social accountability. And then I'd like to move on to the challenges. So there were practical challenges such as there's no resources to support members of the public like myself until the project is funded. So that in turn perpetuates the involvement of what you might term usual suspects, because I can afford to work for nearly 4 years without being paid and to run my car if I need to, but many people can't. So you're immediately closing off and shutting down a whole lot of ideas, really good ideas, I think, they don't have the opportunity to go anywhere. And then navigating the online application process and understanding research terminology. So, for example, in the early days, it was a real struggle for me as a dyslexic to chair meetings, take notes and understand new concepts simultaneously. I really found that hard. And then my attempts to conduct the literature review, again, this was early on in the development of the project, was hugely challenging as I had no formal training in this area and no library access, or limited library access, I should say. And as a result, I even had to make a couple of trips to Essex University Library in Southend. But thankfully, once the project became viable, a research assistant at NSFT took over that literature review work, and I was so relieved. One huge mistake I made was choosing a co-lead without doing my homework, because it was only later on after on that I discovered that this professor of clinical mental health nursing was already overcommitted. It was really, I can't tell you how much sleep I lost over the weekend, because I knew it was going to be a difficult conversation, and it really was tricky to navigate. But I did have it. I did, you know, I thought I wondered if I could do it, but I did have a really honest and open chat with her about, you know, why I didn't think she was the right person for the role. It was very difficult as a service user and someone with lived experience to say that to someone who's a professor, actually, but I managed to do it. But that left me with the problem that I didn't have a co-lead. So it was absolutely a great stroke of luck when I was at an applied research collaboration East of England event that I was sat near to John Wilson. I had met John through my involvement with the Promise programme, and I felt that he had the right values, experience and credibility to co-lead the project. Our chance meeting gave me the perfect opportunity to thrust a 2-page outline plan for a research project focused on improving discharge processes into his hand. And of course I followed it up, as I have that sort of persistent nature. And in terms of the cultural barriers, there is a risk of lived experience knowledge being equated with symptoms and questions about reliability. So there was this comment from one of our external reviewers. Now, it could be interpreted in two ways, and I completely, I completely get that. But from a lived experience perspective, this sentence, following on from the above, I am concerned that the co-lead, who is an expert by experience, has the largest full-time equivalent of all, and in the light of the ambitious nature of the project, it could be highly demanding. So I sort of felt that was a little bit of a query about, you know, whether I could actually, you know, fulfill the role. And then, in addition, I have challenged, unsuccessfully, I have to say, but I'm not going to let that one go, the power differentials that are perpetuated by the NIHR. And I did that in a meeting with Jeremy Taylor from the NIHR Centre for Dissemination and Engagement. So engagement and dissemination, I can't remember, one of those. Anyway, for example, the structure and format of the application form gives that impression that our collaboration is not regarded as an equal partnership. I do understand that the host trust is accountable for delivering the project, and there is a need to comply with the ethical regulations and the governance requirement, but I do not see any reason why I cannot receive the outcome letters and other communications directly from the NIHR. And I suppose I haven't put this challenge down, but I suppose one challenge that I also have had to grapple with is that I have no academic qualifications. So some of the sort of the conversations are way above my level, and my lack of academic qualifications was because my mental health issues totally derailed my education at sixth form level. But that's where my research design centre, service, sorry, I'm getting my words muddled up. The East of England Research Design Service, my colleagues there, they really helped with me to unpick some of the methodology and go over things with me. So that was very helpful, as well as the team members, you know, but I think everybody had to put in a bit of extra work there. So just to end, I'd like to say that it was really lucky at the outset that I didn't know what I didn't know. I think if I'd been able to look into a crystal ball to see how long the application process would take from start to finish, I would probably never have embarked on the project. However, in this instance, my OCD has turned out to be a great asset because it's given me the tenacity to keep going when I think a lot of other people might have given up. And that's just where I want to finish, really, and to thank everybody. I think we've got a thank you slide. That's it, I think, from me.
Lovely, thank you, Sarah. That's really interesting. Shall we turn to questions? see, I know, Bonnie, you've been monitoring the chat a bit.
I have been monitoring the chat. We've had lots of positive, supportive comments for all three of our speakers today. We haven't had actually any questions as yet. So Amanda completely agrees with you, Sarah, about I'm also challenging some of the ethics understanding from the NIHR and I guess research culture and system as a whole. So why we need people with lived experience looking at things through another lens and perspective. Absolutely. So the brilliant presentations to everyone today. Thank you ever so much. Does anyone have any questions that they'd like to ask? I can see one hand up, which is very exciting. Let's have a look. I can't actually see anybody. Here we go. Bryony, you got your hand up.
Thank you, Bonnie. And thank you, Sarah. That was so interesting. And thank you, everyone, for the presentations today. It's been a really, really fascinating session. I just wanted to follow up on your point about the barriers that the NIHR, I guess, places to having researchers with lived experience kind of on an equal footing, Sarah. I think that's fascinating, given how much, I guess, lip service is paid to it by the NIHR, that perhaps actually they're part of the problem in some ways. Really interesting. I'm just wondering what you think they could do to make that better. What steps do you think they could take to make sure that people are able to have that equal footing? Ooh.
I think
So
we've
Sarah
just lost Sarah.
Out,
Just to explain to Peggy, the NIHR is one of our main medical funders. It's the National Institute of Health Research in the UK. And yeah, there's certainly, I think, Amanda, you had a similar kind of perspective. So I don't know if you want to pick that up from your experience.
I guess that it's asking them to take a look. It's the same thing that I think sometimes happens when we challenge things as peer support workers in the trust, that it's until someone looks at it and says, why are we doing it this way? People say, well, because we've always done it that way. And that sometimes the same thing, kind of these same conversations that we have with people from NIHR and other places, that actually I have the same conversations with King sometimes, and I just said it doesn't make any sense that you're asking me to do it this way. This doesn't work for me. There's another way that I can do the same. I can achieve the same thing that you're asking me to do. I just don't want to do it this way. And it's not until you kind of stand up and just kind of question it and query it and just ask that things change.
It's so interesting because probably many people could develop some stress or substance abuse or mental health challenges from the rigor and stress. So it's like all researchers are experiencing that. So maybe something has to change of the way you have this, if you're assuming this person, but I see this thing, we're all at risk, right? And especially if they have oppressive ways of handling things. So maybe it might help them to rethink that question, that for anybody, it's a stressful situation. So perhaps that lived experience gave you the resilience to do it even better.
Because they give out guidance saying that, setting a high expectation that, co-production is the gold standard, and people should be working towards that if they're not doing it already, etc., etc. And yet, when it comes to those application forms, I felt even the fact that we had to justify the need for a co-lead. I had to write a justification for the co-lead. It just doesn't convey equal expertise, and I feel so strongly about that. As I said, that I got in touch, and they didn't come back to me after I had this conversation with Jeremy Taylor and a colleague, and I also involved Tracy Johns from the Research Design Service. They didn't come back to me, and I chased them a couple of times, as I'm very inclined to do. And eventually I got quite cross and I sent a bit of a waspish email, but I will get back in touch with them, because I think not receiving outcome letters when you're a co-lead is appalling. I think that is just wrong.
Quickly, while we're
Well, I was just going to the defence of the NHR. They've gone about it in a way which shoots themselves in the foot repeatedly, but they have given £1 million to fund a project which has never been done before. No one's ever done this before. So they've taken a bit of a gamble on us, and that brings with it a sense of pressure, doesn't it, Sarah? Actually, we've spent far more or less than they've spent any other trial like. Well, actually, there's never been a trial like it with the engineering things. So we are breaking new ground in a Star Trek sort of sense, aren't we?
Yeah, I think we are, and I think having, a non-academic, member of the public co-leading is probably not that common as well, because I do know other people with lived experience, but they usually have a research background or some knowledge of research, or at least are very well qualified. So I think that's also fairly new ground.
Will any NSFT walks form part of the individual case studies for mines? I think you said there was going to be 2 walks per trust. Is that right?
Yes.
I won't ask if they've been identified yet.
Well,
That's
no, because actually,
topic, I think.
no, well, part of the realist review and the sort of initial stakeholder consultation work as part of the realist initial kind of program theory development will help us to think about what wards would suit the research questions in terms of issues like diversity, geographical location, connectedness in terms of things like being able to have public transport, the sorts of things that we think will be really critical in understanding the discharge experience. So that's as yet to be determined.
And they'll be chosen sort of as a representative across the sit, so you'd be looking for different
exactly. So that's part of the reason why we're working with London and Hertfordshire to get a bit of a range of experience of discharge.
Lovely, thank you. Now, Louise, you've had your hand up and you've put it down.
There was another question in the chat, Bonnie, about a network of lived experience researchers. I noticed a few people responded, but I don't know if that's something that's worth discussing. Amanda, I see your.
So I'm connecting. I mean, I connect over. I recently started doing Twitter, which I had always avoided, and then now I can see a point of it, and now I'm addicted, which is just terrible. But actually, there are networks of lived experience researchers, and it's really useful to connect with them. Absolutely. We all share some kind of common frustrations and common experiences. So, yeah.
Which ones would you recommend, or would panel members recommend?
I don't know if we actually necessarily have a formal name. We just have kind of all convened, or we just kind of find each other. I don't know that I don't know that there's necessarily a formal name.
I think the NSUN have so the National Survivor User Network. I think so. I think Peter Beresford's been quite involved in some. I think that they may call themselves survivor researchers, or used to. I don't know, Sarah. You're probably more.
Yeah, the meeting I join is the MAD Studies.
Yeah, it's MAD Studies.
MAD Studies meetings, which are held once a month, and they're really interesting.
There was a paper in the Psychiatric Services not too long ago that I think it was by Nev Jones and some other people that might be might be something to look at. Psychiatric Services Journal did a piece on that, and it's actually been trying to cultivate more articles. So it might be something for dissemination for a lot of lived experience researchers as a pretty good journal to potentially publish in.
That was another question, wasn't it, around the dissemination that Claire Mutimer asked. I don't know if you want to ask that question, Claire. Sorry, you probably fell asleep and I've just woken you up.
I was like,
sugar,
wake up. No. Yeah, no, I was just, I do the communications for the research team, so I'm always interested in like how you think the best way is to disseminate your research, and particularly obviously from a lived experience point of view.
Well, publications is really, I think, a big piece, even though some people don't really, it's not important to people, but I think getting the word out, getting it into publication, it actually elevates, there's a respect that people sometimes might have for the work. So it is one of the ways that many people find is, it can elevate your work in a different way. So just, again, and then presentations, I think there's been a couple things here, but I think that it's powerful when you can get some work out there and people can see that. And I think it's also powerful when there's a collaboration of people there. I think it really provides great role modeling.
That's really interesting. And I was really interested to know whether, like, also, does that not perpetuate sort of this kind of different level of, research where people can't access it so easily? So I was sort of wondering whether.
Yeah, that's why I said
it actually go hand in hand with other things, or.
I think that's one of the things I wrote in there, is that one of the other ways is try to distill this information into usable information. And I think that's a way to bring it out to the public, out to the streets, like and that's really where helping find better, like have it in journals, but then get it out onto the street, get it out into the hands of people. And that's really where I think I could get some valuable feedback on how to translate that information, data, whatever out there, and using good health literacy principles around people understanding and then getting to use this information.
That's great.
Yeah, completely agree. Thank you. Amanda or Sarah, do you have any insights about disseminating your work? Kind of who's your audience? Who do you see your audience being? I think will be one key question.
It's an interesting question, because I'm currently kind of fighting with that with my autoethnography, because it could very easily position itself within that kind of activism, survivor research place. But actually, whether or not that serves me within the wider sphere of the whole project and the whole study, I'm not 100% convinced at the moment. So at the moment, I'm kind of looking at, I don't know where the actual autoethnography bit, the lived experience bit, sits comfortably at the moment, because there's definitely there's places like Asylum magazine and all of those kind of magazines that really do cater for that kind of crossover where lived experience researchers sit within activism and campaigning and pushing kind of the cultural, the political, social change.
Thank you. I didn't know, Sarah, if you had any comments. Well, sorry, I've got don't pass me at the moment.
So I suppose for me, it would be, I would really want to share the findings with people who are working on the wards. Someone like Joy, who's, as Karina mentioned, says, tells me every time I see her how difficult, how stretched they are, and how staff don't really know what they should be doing in terms of discharge planning, and even if they did, they don't have time to do it, and all these things. So I'd really want to communicate the findings to those people. But very importantly, I think service users. I mean, when we've done this work and we know more about what good looks like in terms of discharge planning, I think people need to know about that, because then they've got a voice. They can ask, they can ask questions and say, well, why didn't I have that information? And it gives them more power to their elbow, in a sense, because if you don't know what you should be able to expect, then you can't sort of query why you haven't had it. Does that make sense?
It does completely. So I had to go on mute because I've just got whatever's going on outside my window at the moment. Sorry. So yeah, absolutely, I completely agree with you.
Can I just add to that, because that just reminded me of other meetings that I sit in. So I sit in a kind of a monthly mental health research network meeting, and they particularly are really focused on how to get research findings into clinical practice faster. So how to kind of embed it into actual processes. So I know that work is going on, but I know that it's challenging and difficult.
There's a reason why it typically takes 15 to 20 years for a research project outcome to get implemented into practice. Hopefully we can speed it up quite a bit. So while we've been talking, oh, sorry, Sarah, did you have another?
Yeah, that was part of the reason that the applied research collaborations were set up, was to speed up that translation of research into practice. And one of the things that they do, which I think is quite a good idea, is they do what are called ARC bites, where they summarise on a card key findings from research projects, so that people can look at them and think, oh yeah, that's something I'd really like to actually read the article. And if not, it just gives them the headline news.
No, it's interesting you brought up the art bites, because we've adapted that.
Yeah.
When they started, we've adapted them and have research recaps with the same purpose, which go on our website and are shared on social media, and we give them out as well. And they're really well liked. It's just written for the public. It's just the key bullet points of why we've done something and what the outcomes and findings are. And then Claire's in charge of podcasts and doing videos, and really, we're on the start of a long journey, I think, about how we share, how we almost bypass that sort of very selective publication culture to really kind of be communicating with the public overall. So while we've been talking, there's been a few sort of questions and answers. So Elizabeth Thacker asked whether the monthly MAD Studies event could be joined, as in, like, is it open membership? And Sarah said absolutely. So I think I mean, you're all trailblazers, and that's why you're here today. So thank you ever so much. It's been really wonderful to hear all your work, your ideas, your passion, your enthusiasm, and your drive and leadership for change. I think it's really inspiring. So thank you all very, very much. And Karine, I don't know if you've just put you on the spot. I don't know if you've got any final words you'd like to say.
No, just that I've really enjoyed this event, and I think it's a good sort of indication of where we're trying to move in the department and in our wider collaborations. I'm really grateful, Peggy, that you've joined us on which day is it again? Thanksgiving? I don't know if Bonnie and I were oblivious, and then we're reminded. So you're probably meant to be on holiday at least, even if you don't celebrate. So thank you so much, and it's been great, because I've been working with these three wonderful women for quite a number of years now. In fact, Amanda, I was thinking that we've known each other for nearly 10 years, which is terrifying. So just thank you, and just very grateful to everyone, and I found it really inspiring as well. And yeah, I don't know, John, if you have anything to add as our director.
No, I don't. I think you've captured. I think the presenters have captured it very well about the importance of making this at the forefront of everything we do in as meaningful a way as we possibly can, and we are trying very, very hard to do that, which is a long way from the academic grants that I go on, where it's about them and their ideas, really.
Yeah, can I just chip in with one final comment, which is, John, you were talking about risk, and what I think you and Karina did was you took a risk with me and my idea, which, as I said, was 2 pages of absolute nonsense, really, when I come to think about it now, and the way that the project's developed. But you took a huge risk, and I don't think there are many people that would have been prepared to do that. So that's been, that was hugely encouraging in the early days, because it was, I was desperate, and I didn't know how to find a co-lead, and especially with my first experience. I knew I had to find someone with credibility who'd held grants before and everything, but I didn't know how to locate that person.
There we go. One big virtual hug between everyone.
Yeah.
So thank you very much to everybody for attending, and that's the final. We're done for 2021. I nearly said 2020. I've lost a year somewhere. 2021 for our seminar series. So hopefully we'll see many of you again next year. It's been lovely that you've all been with us. So thank you very much, everyone, and I shall stop recording.